Hey there, this is Michael Bruinix and I'm a clinical social worker at Providence Care Hospital. I work on an outpatient unit and this is module 2 of the clinical training series that I created for clinicians and mental health professionals that are trying to improve their skills in working with complex and challenging clients. So today's module is about the principles of effective therapy that come from dialectical behavioral therapy. So DBT was created by Marsha Linehan. She herself suffered from borderline personality disorder, and she created a therapy to attend to different issues that people have when they have borderline personality disorder. What I'm thinking here in this video is that there's some principles from DBT that can be very effective for working with any challenging or complex situations with clients, and that's what I'm going to walk you through in this video. So let's just dive in right away. Now, one of the reasons I selected DBT as a type of therapy to use to base this framework on is that it's evidence-based practice. And we know the research about evidence-based practice isn't perfect. We know that there's some gaps in evidence-based practice, but one of the things I really like about dialectical behavioral therapy, or DBT, is that it's been tested with a randomized controlled trial. It's been done over many different RCTs, different experiments. There's been a Cochrane review, that's COCHRANE. There's the NICE guidelines in the UK that recommend DBT. CAMH, which is one of the top hospitals in Canada, has protocols regarding personality disorder or borderline personality disorder. They have a personality disorder unit and clinic. Also in the United States, the National Institute of Health has an arm that's called the National Institute of Mental Health, the NIMH, and all of these very well-known and well-researched organizations support the use of DBT for people when they have borderline personality disorder or emotion dysregulation challenges. And so what I'm doing here in this video is I'm saying there's some ideas from DBT that we can take and apply in various situations when clients need maybe more structure. The approach that you're taking right now isn't working. This is an alternate. Sometimes you'll find that you're working with someone and the thing that you're hoping is going to work actually is making the situation worse. And what I like about DBT is they have specific techniques and they have different ways of approaching the situation that can change the clinician's mindset, and then that helps the client move forward. So I'm going to review those key principles and ideas. If you're already familiar with DBT, what I've found when I'm training other people is they found that these principles, when we apply them in certain instances, can be very, very effective. So for some of you, it might be a refresher. Some of you, it might be a new perspective. And some might just say, okay, I'm going to take parts of this. I'm going to take bits and pieces of this, and I'm going to incorporate it into my practice now. So we'll just see where that goes for you as you're watching. But for myself, when I was working at the Personality Disorder Service for 5 years, there were 3 principal models that were used for therapy. There was transference-focused therapy by Kernberg, Yeomans, and Clarkin. There's mentalization-based therapy, which is by Fonagy and Bateman. And then we have dialectical behavioral therapy, which is from Marsha Linehan. Now, when I was at McGill, what they talked about in the research is that no model by itself can solve all problems or solve all challenges or all situations for clients when they're presenting with various issues. So it's very important to have an eclectic approach where you're borrowing different models for different instances. Nothing out there is going to solve everything for everyone, and I'm certainly not saying that about DBT. DBT has some gaps as well, but if you're finding, okay, you know what, you've got different tools in the toolbox and you're working with people and you're not sure why something isn't working, what I'm suggesting is that maybe some of the principles of DBT and why it's been a researched and considered an effective evidence-based practice therapy is that there's some fundamentals to it that can be very useful to know in clinical practice. So we're just going to review that here and see whether that's of benefit to you. So some elements of effective therapies in general are that there's a clear therapeutic framework. There's been lots of research from the University of Ottawa, has the Faculty of Medicine, and they have a newsletter they release called the PPPR.net. And in there, they talk about how important the therapeutic alliance is, and it's basically a newsletter on knowledge translation, or KT. You've got different researchers out there trying to solve different problems, and you've got different clinicians in the real world working with people with those problems. And what the pppr.net does is it synthesizes meta-analyses, and it takes different clinical data, and then it presents it in a way that has clinical implications, and the clinician can quickly take that research information and then apply it to the clients when they present with different challenges. Now, one of the things that's been shown in research is that when you have a very clear therapeutic framework, in other words, you have very clear guidelines, roles, rules, expectations, that can help a lot of clients build trust. It can help with feeling of a sense of authenticity, accountability, and transparency. And so DBT has very, very clear guidelines. It's I think, a forerunner in terms of a type of therapy that helps clinicians set down clear guidelines. So not just DBT has that, but principles of effective therapy is that you have these clear guidelines, clear therapeutic framework. What that means is, what are you offering in terms of role clarity? What are the rules and expectations in terms of what you're offering? And then what can the client expect in terms of service? And DBT is very good at spelling that out. Another thing I would say, and this comes more from the psychodynamic literature, but it's paying attention to the clinician's reactions. If you're working with someone and you're finding you're getting very sad, because sometimes people tell us stories that are it's just so painful to hear. If you're noticing your sadness is going up, your anger, your fear, even your contentment or your pleasure of working with someone, these reactions are very, very important to pay attention to. Again, from the research from PPPR.net, when you're connected to your reactions, it often is a diagnostic clue as to what's going on inside of your client, who may have difficulty with expressing their emotions. But paying attention to your emotions is very important. The clinical term for that is countertransference. Those are your reactions to your clients. I would say that's very important, and we're going to be having a module later on that. I think it'll be one of the last modules, is because of its complexity. There's other things we have to lay down first, but paying attention to your reactions while working with someone is a very important element of an effective therapy. And then lastly, this is a DBT principle that is often utilized, is an acceptance of what can't be controlled. When I'm working with various clinicians and I'm offering consultations, I get numerous questions about, what do I do if a client says they're going to harm themselves, or they're going to even think about or complete suicide? Of course, you've got to document everything. You have to provide that client in that moment of crisis a helpline, a crisis line, tell them where to go, which emergency department. We have their safety is paramount. But what we have to also accept is we don't have any control over what they do. We don't have any control over that. So we have to act in a way where we know what the limits are of our ability. And I think that's a really important element in DBT, is that there's a strong emphasis that the clinician or practitioner has limits to what they can do and how they can help. And if you can keep that in mind, these other elements that we're talking about will start to make sense. Now, the DBT research that I'm referring to with the randomized controlled trials, I should mention a couple of things. First of all, when I am practicing DBT, the DBT type I'm doing at the hospital is DBT based. To have complete fidelity to the research model, it requires that a participant is in ongoing group therapy for a year, taking the 4 modules of DBT, of group therapy. It also means that the client is engaged in weekly individual appointments with a DBT trained clinician, and that same clinician is accessible 24/7 by phone. And when they were doing the randomized controlled trials and the research, they were assuming that practitioners were doing those 3 elements, whereas in reality, most outpatient services or most hospital services, or even in private practice, that's just not possible. We don't have the resources. We have too few clinicians and too many clients with these types of difficulties. So when I'm talking about these DBT effective principles, what we want to do is look at the research, and then we apply it to the situation that we're in, and we see, can we translate the research into practice, right? Constant challenge. You know this from, if you've looked at knowledge translation at all, you know this is a major concern, is that are we using research to inform our practice? So what I'm doing in this video is I'm summarizing the principles of what DBT found to be effective, and then trying to help you translate across into your practice. So the DBT research showed that when it was adhered to the model that I suggested, that it decreases self-harm, decreased hospitalizations, decreased anxiety and depression. This was done via self-report. Clients take tests pre and post the treatment, anxiety and depression goes down, and decreased the therapy dropout rates. It also increased the clients who participated with their social adjustment, and it continued to show benefit even 2 years later after treatment. So that's what the research is showing us when you stick to the clear DBT model. And I think there's some principles there that are worth examining in terms of saying, okay, I think this is a valid approach. It's a model. It's only going to be able to tackle a part of things, but here's where you want to use that. If you've got clients with difficulty with emotion regulation, so I would argue that someone with generalized anxiety disorder or major depressive disorder has trouble with emotion regulation. Okay, there may be an organic or pharmacological base as to why that is the case, but nevertheless, we also know that psychotherapy in conjunction with pharmacotherapy can be very effective. So if you think about different diagnoses that are in the DSM-5, I think a lot of them, if you look at the common factors, a lot of them have this issue around emotion dysregulation, and I think DBT is a very strong proponent of teaching clients skills to be able to deal with that. If they're having issues with keeping themselves safe, or they have multiple diagnoses, so in the outpatient clinic I worked in, people would often have between 6 and 11 diagnoses. So if you have a really complex case, or they're presenting with really challenging behavior, sometimes the principles from DBT can be very effective to keep in the back of your mind in terms of the rules, the ground rules that you set down. The clinical term for that is therapeutic frame. How you say something, when you say it, what you say, the clinical term for that is therapeutic stance. When you keep those ideas in mind about what DBT has to offer, if you combine therapeutic frame with the therapeutic stance, and you talk about the therapeutic alliance, and all those are clinical terms talking about the relationship you have with your client, there's some really interesting points that DBT makes about how to do that. So we'll just have a look, and we'll see whether that's of value to you. Now, one of the things I often get asked about is, when someone has a personality disorder, how does that happen? Like how does someone acquire that? Or are we born with it? Is it the environment we're raised in? Because we have research showing that people can have borderline personality disorder and they didn't suffer trauma per se. We also know that sometimes the person has difficulty with interacting with others, and it's just genetic. For example, research shows that if you are born to a parent who has anxiety or depression, you're 40% more likely to have anxiety and depression. The clinical term for that is genetic loading. So we know genetic loading exists for schizophrenia and psychosis and with some addictions. So we have to think about, okay, maybe there's an element of personality disorder that's genetic. And when I was looking at the research from Dr. Rex Kay from University of Toronto, he was saying that 45% of what a client is experiencing comes from genetics, whereas 55% comes from the environment. So the biosocial theory by Marshall Linehan, of which I can't find anything in the research to support that the biosocial theory is valid. It looks like it has sort of face validity, like it seems like, okay, if we know that about anxiety and depression, or we know that about addictions, that genetic loading is a factor, it kind of stands to reason that a personality disorder could be like that too. But the other part about the environment, see, there's so many variables. What constitutes an environment, If a child's in foster care, or if a child has a kin placement, or the child has one parent, but one of the parents passes away, like there's so many variables. Can we definitively say every time, oh yeah, that's 55% environment, it's 45% genetic loading. I think it's really hard to make clear delineations about that, but what makes that face validity, what makes sense is that there's going to be an external component to it, meaning if you're raised in a family of people that get really angry and they yell a lot, isn't it more likely that your client is going to be someone who yells a lot? Possibly. If that client comes from a family where they repress their sadness. So I've worked with some clients where once someone passes away, that family never talks about them again. So remember when we were talking about those 6 emotions, right? Fear, anger, sadness, guilt, shame, and joy. When we're talking about those 6 emotions, how the client's family deals with each of those 6 emotions. Are they people who quickly express that they're upset and angry? Or are they people that hold it in and then, you're sitting around the dinner table and you're eating and everyone's eating quietly, but you can feel the tension, you can cut it with a knife. Every family could deal with what generation they come from, it could deal with what culture they come from, could be gender related as to how we express emotion. Like, men are generally discouraged from being upset or sad or expressing sadness, and I would argue that most women are not encouraged to express anger. And so some emotions are gendered. Sometimes it's about your culture. Certain cultures deal with certain emotions in a particular way. I, from a British background, know for a fact that with parts of my family, expression of emotion is discouraged. That's cultural, how we connect with each other culturally. What are those rules and expectations? So when we're looking at the biosocial theory from Marshall Linehan, what I'm saying is that obviously human beings are made of very complex elements. I'm not sure we can reduce it down and have clear, definitive research about whether the biosocial theory is accurate or not, but it sure seems like there's a genetic component to how people behave, and there's an environmental component. And so what Marshall Linehan's inviting us to think about is those elements may have contributed to why someone has a personality disorder or personality disorders, because as I mentioned in the last video on the introduction to personality disorder, when you have a personality disorder, it's often comorbid, concurrent, or occurs with another personality disorder. So let's say that the biosocial theory by Marshall Linehan is true. Let's just take that assumption. We can examine the evidence and the research. And we also know from our own lived experience, okay, that seems possible. So then when you're in a family that's not treating you well, either it's a neglect or abuse, what Marshall Linehan stated was that's an invalidating environment. So an invalidating environment. So the example I often give is about a mother who takes her 2 sons to the ice cream store. And with the first son, we'll call him Timmy, he goes in with mom, and mom says, what type of ice cream would you like today? And Timmy says, oh, I want the chocolate mint. And the mother's really pleased. Like, that's fantastic, Timmy. You keep trying new things. That's really good. And how about for you, Tommy? What do you think you'd like today? And Tommy's like, oh, I'd like vanilla. I'd like the vanilla ice cream. That'd be great. And the mother says, oh, Tommy, like, why can't you be more like Timmy? Like, he tries new things. Whenever we come in here, you always say you want the vanilla. Can't you be different? See? Now, that small example, it could have been with a dad, an aunt, a grandmother, or a hockey coach. Every time the person on the outside is saying what you want, what you need, what you think is important isn't important, and in fact, not only is it not important, but it's actually the wrong thing to do. If you have hundreds or thousands of interactions like that, Marshall Linehan postulates that that's invalidating. And if you do that to someone over and over and over again, it has certain effects on their personality structure. Kind of makes sense, right? So what happens here is when someone's in a or an invalidating environment or a place where they don't feel supported, it can have different effects. Now, you can feel invalidation can occur directly or indirectly. What I just talked about with the 2 boys in the ice cream store, that's directly, right? The mother's disapproving of one and approving of the other. Arguably, you could say that's a form of invalidation for Tommy. Now, the other type of invalidation occurs, which is indirect, and that is where the family, maybe they come from a background of sports and they really love sports. And I worked with a client once who was really into rugby, and all of her family was into rugby. And when she wanted to give that up, her family got really upset about that. Like, part of their family story, part of their identity was around rugby. So there, maybe deep down inside, you may not be an athletic person, but you're surrounded by people who are athletic, and then it can feel like it's invalidating because actually you want to be a musician or you want to go to university. It's not done deliberately to you. It's just, if you come from a family of doctors and lawyers, or you come from a family of people who work with their hands and they're good with trades, or and you're not, it can be an invalidating experience because what matters to you is trivialized, marginalized, or sometimes even actively punished. And that has an effect on people over time. So over time, what it does is it erodes the person's trust in themselves. They thought they wanted vanilla ice cream. They thought they wanted to go to university. They thought they wanted to take up a musical instrument. But the family, either directly or indirectly, invalidates them. And then you start questioning and doubting yourself. One of the core elements of someone with a personality disorder, particularly borderline personality disorder, is their sense of identity, right? Personality disorder, of course, implies personality structure. So it's who you think you are. And does that match? Does it work with everyone around you? When someone has a personality disorder, the way they're being is very difficult for other people. One of the core issues with people with borderline personality disorder who are diagnosed with that is they don't have a strong sense of self, meaning when they're around mom, they might be this version of themselves. When they're around their boss, they're this version of themselves. When they're around their partner, they're that version of themselves. And we all do that to some extent, but for people with moderate to severe borderline personality disorder, they're truly lost. It's as if the person in front of them is a mirror, like, oh, that's the way I'm supposed to be right now. Oh, those are the rules. That's what it is. And then they lose that image, and then they create another image, and they're trying to be a different version of themselves over here, which is why some clinicians, when they're working with someone with personality disorder, they're fine. It's totally fine. They're not experiencing any trouble or problems. Whereas for someone else who may set off something unconsciously, or it's a challenge around authority, accountability, that it is a problem for them. So you'll find that when someone has, in particular, borderline personality disorder, identity is a core issue here, where it's not very stable or it's not very secure. In other types of personality disorder, such as narcissistic or avoidant, actually the identity is very secure, and then it doesn't move very much. So one of the challenges you'll find when someone has a personality disorder is their personality structure. In other words, the way they are in the world can be either too rigid, that's on one end of the spectrum, or it can be too fluid, which is on the other end, meaning I don't really know who I am, or I know exactly who I am, and you better conform to what I'm asking you to do right now. Both of those extremes can be very challenging to work with in different ways. And I think that the invalidation can sometimes make people double down and become really rigid with how they go through the world, or they can become very fluid, trying to accommodate, almost act like a chameleon. Lots of clients I've worked with borderline personality disorder, they say that they can really morph into anything. They do whatever they can just to make it work with that person. Unfortunately, over time, that builds up other types of problems. But when you're in an invalidating environment, that's a survival mechanism, wouldn't you say? That you're trying to adapt, right? If we think about Timmy with the chocolate mint, and he's being rewarded, seen as good, and Tommy, who has the vanilla ice cream, he wants vanilla. If he suddenly switches over, that's adaptive. If he stays with what he's doing, maybe that just leads to more problems and more arguments and more challenges. But over time, either way, you lose yourself somehow. And I think that's part of the consequences of having been raised in an invalidating environment. And of course, nothing is so black or white. You may have a family member or family members who are very supportive and giving, and then there's this other family member who can be very critical, very demeaning. Sometimes they might shame you or make you feel guilty. And so, of course, there's so many factors here, but what we want to look at in terms of what DBT is saying as to where personality disorder comes from is invalidating an invalidating environment is part of what creates that situation. And so when someone has when they've been invalidated many times, hundreds or thousands of times, what happens is they start to think there's something wrong with them, that something is broken in them. Remember, I was talking in the first video in the introduction to personality disorder that people will see themselves as hateful or defective or they're damaged in some way, especially if they've been diagnosed with borderline personality disorder. Well, that comes from being invalidated over and over, where after a while you're thinking, hey, maybe there is something wrong with me because the feedback I'm getting is what I'm doing isn't working. So after a while, it can feel like everyone else has the answers. I don't have the answers. I don't know what the right answer is. You got to tell me what the right answer is. And I've sure had many clients come to me saying, I don't know what's right for me, but I think you do. You've got education. You've got experience. You know, you've been working here. You're the expert. So tell me what the right answer is. See, that's a consequence of invalidation, that they don't know for themselves. That's why I think the concept of wise mind that Marshall Linehan talks about, and I'm going to talk about in later modules, is really important because it teaches a client to get connected to themselves, to listen to themselves. And I think that's part of the attachment repair. It's a part of healing their relationship to themselves and starting to see the world in a different way. So these are, for me, when I see the types of problems that people come to the outpatient clinic for, I think that invalidation is a definite element of what causes them to be the way that they are. So other effects of invalidation are you start to become afraid of your own emotions. Maybe your emotions are really intense, or when you were younger, having emotions got you in trouble. You know, if you've got a child who's in a classroom and they're feeling intense emotion and they don't know what to do with it and they're, you know, moving around or they're restlessly kicking their leg, or you see, what we're often taught in an invalidating environment is emotions aren't good. You know, if you're being a good boy or a good girl, you would be behaving like this, not like that. So over time, if you're exposed to an invalidating environment, is you start to feel like you've just got to get rid of your emotions or not feel your emotions, block out your emotions. And so that's a consequence, is that the client's relationship to their own emotional self begins to become compromised the longer and longer that they're raised in that type of negative environment. And of course, if you're feeling, as I talked about in the other video, Introduction to Personality Disorder, and I was saying that clients have different emotional levels. So as they're going through the day, their sadness is going up and down, their fear is going up and down, their anger is going up and down. That I was saying that they don't feel like they're in control. It feels like other people are pushing their buttons. It feels like other people are in charge of how they feel internally. What's the only answer? What's an answer a lot of us do is we use behavior to take the edge off. Let's say I'm angry or upset about how my boss or a coworker talked to me. Well, maybe I drive home quicker, like I'm speeding in a certain area. I'm doing something, I'm using a behavior just to let out my frustration, but it's not to do with speeding or what's going on the road. It's that I've got these emotions and I don't know how to deal with them, right? It goes back to not having the right skill set, not knowing how to work with your emotions. And so you can overeat, you can undereat. You can overexercise, you can underexercise. Overspend, underspend. There's these extremes. That's what happens when people have personality disorder, or when you have clients that are complex and challenging. And this is what I'm talking about, is that you can take some principles from DBT and from personality disorder, and you can apply it across to other different populations and people with different types of challenges, where we know that when a client is not acting in their best interest, what the clinical term for that is acting out, it's that they're using behavior to take the edge off of their emotion. So it's totally understandable. We do it all the time. I do it all the time. It's learning how to work with that in a constructive way, but know that the invalidation is a cause for why people do this. So it's if we think about it, if you think it through, a lot of people have access to a wise mind. We know what we should or shouldn't be doing, and then we do or don't do it, right? This is about choices in every moment. And I think what I like about DBT is, one, it points out that clients have choices. 2, that clients don't always make the best choices, including us as clinicians. And 3, it's a skill we can get better at. I think that's a very compassionate and very intelligent approach to working with people who have these types of challenges. And the compassion for me increases when I think about, hey, they've been raised in an invalidating environment, possibly. So I've got to explore that, look into that, rather than being someone else who is perpetrating that form of invalidation. In a sense, if this happens long enough, really the person becomes, the clinical term for this is they become other directed. They start looking for a doctor, a psychiatrist. They start looking for a caseworker, a partner. They want a boss. They want other people to care for them, to take responsibility for them, look after them. And those are consequences of being raised in an invalidating environment where you no longer trust your wise mind. You don't trust your own self, your own judgment. You've made mistakes in the past, and now you're thinking other people can help you instead of you helping you. DBT has such a strong focus on turning it back to the client and helping them go with their inner resources and solving problems from there. I think that's really great. So lastly, with the effects of invalidation, you can have these rigid cognitive positions. You can take a really strong stand on certain things. That is right, that is wrong. And you're doing that because it sounds like these types of behaviors lead to trouble, but actually they're a protective mechanism, right? If you can suddenly figure out what's right and wrong in a situation, example, Timmy chose chocolate mint, and next time he goes and he chooses tiger tail, he knows, okay, this is what I got to do in order to keep a good connection with my mom. Whereas Tommy, he's taking maybe a certain position that's not working out well. So there's this question of, am I going to adapt to my environment, or am I going to stick to my guns and stay with what I know is true? This is a struggle, I think, that everyone experiences at some points in their life. And when someone has a borderline personality disorder, then that very problem just becomes magnified, it becomes amplified. You can see that they can become very fluid or they can become very rigid. Also, it's growing up, if you're in an invalidating environment, direct or indirect, you've got to get people's attention somehow, because you're feeling like what's going on inside isn't important. I don't know if you've ever been to Toys R Us where a parent's there with their child says, I want this Lego set, I want this Lego set. Parent says, no, no, no. Child keeps getting upset. Why are they getting upset? They don't feel like they're being listened to. They don't feel like they're being cared for. Right or wrong, in that moment, the child feels invalidated, like what matters to them is not important to the parent. So what some clients learn as they're getting older, as they're going through this environment, they find that they need more and more extreme displays of behavior in order to get their needs met. I really believe that personality disorder is an attachment disorder. I've got to say that if you look at the attachment literature from Bowlby and Main and Ainsworth, you're going to see that a lot of the information that they talk about connection to other people, that interruption of connection, and I think invalidation is a form of interruption, causes people to change their ways and try to get their needs met. So for me, when I'm thinking about whether someone has a personality disorder or a mood disorder, or they're addicted to a certain substance, they have an eating disorder, I'm thinking about what are their unmet needs? How are we going to work with this? And what I like is DBT taps into teaching clients skills about how to work with that. Now, what are we going to notice when someone's been in an invalidating environment much or all of their life? Okay, we're going to see 6 different patterns. This particularly applies to borderline personality disorder, but you may see traits or features with clients that you're working with when you're struggling about, what do I do? Do I discharge them? I mean, they've been to different organizations. I'm their 4th worker. Again, what's this video about? It's about working with people with complex or challenging situations or behaviors, and you're not sure what to do. I want you to think, okay, here's some possibilities. Here's maybe why they're doing it. Here are some things I can do with the therapeutic framework or the therapeutic stance. I can make a better connection with them. So with their behavior, there's 6 things you might notice are happening. And as I'm talking to you in this video, you might even be thinking about clients in the past or clients you're working with right now, and you're like, whoa, that fits that person really well. this doesn't apply to every client, but I find these underlying structures occur a lot with my clients, so that's why I'm pointing them out to you. The first one is emotional vulnerability. When the client's feeling vulnerable inside, they may start blaming everyone on the outside. In other words, if my doctor would just give me the medication I want, or if I'm in a long-term care home and the nurse would just give me the PRN that I want, or if my case manager would meet me 3 times a week like I want, then I'd feel better. But we know when clients are really challenged with a variety of different problems in their life, you can give them those things, you can give them the medication, give them the appointments, give them the homework, and they need more. Now it's my mother, she's upsetting me with the text she's saying. Oh, my partner, he's upsetting me because he's saying this or that. My kids are upsetting me because they're doing this. And the idea here is that we're blaming external circumstances for our internal state. That's a very common clinical presentation, and it's just a question of whether that's mild, moderate, or severe. And the research shows is that the more someone externalizes and blames the environment for what that is, the harder it is for them to recover from what's going on. The second thing is that after a while, if you've been in an invalidating environment, you learn to self-invalidate. You have unrealistic expectations or demands for yourself or others, and you try to impose them on others. So you learn that what you think and feel isn't important. So one of the things you might do, or a client might do, is they start trying to become perfect or getting better or improving at something, as though then they're going to be loved. And you see, when we talk about Timmy and Tommy, like the mother was saying, like if you could be more like Timmy, right? The underlying thing there in the invalidating environment is that, oh, if you're like this, I will love you more than if you're like this. How can that not affect you deeply as to who you are and what you're doing in life? So you start to learn to either dislike or hate yourself, because why am I like this? Why is my brother perfect? Why does he always get all the share and the care from my mom? Or you say, you know what, I'm going to take it up a notch and I'm going to get better at doing whatever it is, playing hockey. I'm going to get better grades. I'm going to take up something in order to get that type of love and care and connection, the attachment. When you have a client working with, and they have borderline personality disorder, been diagnosed with that, often what you'll see is a pattern of unrelenting crises. It's just crisis after crisis. Things keep going on in their life that create chaos. That is a behavior that happens when you're in a state of invalidation all the time. It always feels like whatever you're doing isn't good enough. It feels like whatever you know isn't enough. You just don't feel like you can handle the situation. You get easily overwhelmed. And why would that be? Your self-esteem is quite low, right? When you're invalidated many, many times, you have low self-esteem, which means you have a low risk. You don't want to take much risk. You don't believe in yourself. You got a lot of self-doubt. And you're going to be afraid of making a mistake. And all of these things are going to contribute to you not feeling good about yourself and wanting to improve or have these perfectionistic demands on yourself in order to get the care and connection that you want. Now, underneath this, whether the person's experienced trauma or not, when you've been in an invalidating environment, what you have is inhibited grieving. So the way I was taught where I worked was that the core of much of psychopathology is that we don't process our losses. And so it's sadness. There's an incredible sadness deep down around what we wanted and what we needed as a baby, as a toddler, as a child, as an adolescent, even as an adult. There's things that we want and need and it's not happening. And we're not grieving our losses. Instead, we're trying to compensate for them, deny them, repress them. You know, Sigmund and Anna Freud talk about the 33 defenses that people use in order to protect themselves, protect their ego from feeling hurt, from feeling wounded, from feeling injured. And when you get invalidated, it hurts. So what happens is maybe you're working with a client and they've had not just this breakup with a person, but they've had many breakups and they haven't processed it. So then the next breakup hurts even more because it's all this unprocessed grief underneath. Similarly, if they didn't process people passing away or pets passing away, people that were important to them moving away, you've got a lot of inhibited grief. It's just laying there inside them. They feel this sadness and they don't know what to do with it. And then they do different behaviors to try to moderate how much they're feeling. It's what Dr. John Briere from UCLA talks about titrating reality. That, if we've got someone who, say, has an alcohol use disorder, right? They got AUD, they're alcoholic. So they drink a couple of drinks, and yes, there's some genetic loading around addiction, so we know that. But let's say there's some feelings of loss inside that they have not dealt with. And so it seems that drinking one glass takes a little bit of the edge off it, but taking 4 or 5, glasses, you feel it less and less. And so what Dr. Briere was talking about when he's talking about titrating reality is that you're numbing yourself out. Here's reality, here's how it is, here's what reality is right now. And then as you drink or as you use your substances, you're pulling further and further away from it, and you pull far away so that you can handle it in a diluted state. I think that's really, really important. I think that explains the core pathology for a lot of what our clients are experiencing, is that they're just trying to get through this moment or this day. They're in survival mode. They're surviving instead of thriving. And part of that stems from having inhibited grief and unprocessed losses. Another behavioral pattern you'll see is active passivity. It'll seem like things are happening to them and they don't take ownership, they don't take responsibility. It's what we can call victim mode. They feel like they're just a victim to life. So they come home, the kids are arguing. Don't know why that is. My partner came in, suddenly she starts yelling at me. I don't know what I did wrong, right? And it goes on and on throughout their day. If you listen to them describing their day, they aren't making active choices. It just feels like things are happening to them. And when people have had prolonged invalidation, you can start taking a very passive stance. And the reason it's called active passivity is there's a role they're playing in it, but they don't see it. So there is an active component to the way that they're approaching life, but it looks very passive to the observer. And the last part is the apparent competence. Sometimes when clients have been in invalidating environments for a long time, they look like they're okay, and they don't give off cues that they're not okay. That's a survival mechanism, right? If in your family, making no noise or drawing no attention to yourself makes it so people don't pick on you or give you a hard time, abuse you or neglect you. If you just stay to yourself and you show yourself as reliant and independent, then you're less of a burden or potentially less of a problem for caregivers. And so that can be a survival mechanism of getting through all this. But apparent competence, really the problem here is our clients can't tell us when they're in distress. They might be feeling all kinds of things inside, but they can't tell us. And so it's very important to tune in. That's why paying attention to the clinician's reactions, sometimes you can tune in to their emotional state from what you're picking up, what you're feeling inside yourself. Even though on the outside, you ask them, how are you doing? I'm fine, I'm good. Okay, well, why are you here in therapy? Or why are you meeting with me if everything's okay? So there's like this veneer, there's this shell that you kind of have to break through when someone displays apparent competence. Some of the assumptions that DBT and Marshall Linehan make about our clients is they're doing the best they can and they want to improve. They may not have caused all their problems, but they have to solve them. This is huge. This is a huge point. Clients can come and talk to us. And when I say clients, you can be a rehabilitation worker, you can be a youth worker, you could be a police officer, you can be a nurse in a long-term care facility. I'm talking about all helping mental health professionals here. When they come to us, sometimes you can hear them saying, I wouldn't be like this if my mother hadn't treated me like that, or my father hadn't done this, or if this hadn't happened in my life. And people can go into therapy or be talking about the same story over and over again for years, where I really wish this hadn't happened, I really wish this hadn't happened. Now, we don't want to invalidate and say, just get over it, because that's just not true. It doesn't work like that. People are more complex than that. On the other hand, we want to support them, but we also want to challenge them a little bit. Look, you've talked about this a lot, and it's not going anywhere. What you have to do is, this is the deal, is you didn't create the mess, but you've got to clean it up. And if you don't clean it up now when you're 22, you're going to have to clean it up at 32 or 42 or 52. Like somewhere along the line, you have to start taking responsibility for what you're going to do, not what happened. You were in a helpless situation. You couldn't do anything about it then, but the choices you're making now, those are things you can do something about. So it's about validating and supporting them with their past, but challenging them and teaching them skills to face the future. I really like that about DBT. I think that's an amazing assumption in terms of working with clients. The other thing is that we're assuming that they have somewhat unbearable lives if they're self-harming or they've made suicide attempts. That tells us right there their lives are unbearable. If they're coming to us for help, it often means that something in their life is unbearable. We make that assumption, and it just means that we have to teach them how to work with that part or those parts of their life that they're finding are unbearable. And we're saying that at the end of the day, this isn't about you. It's not about you. It's about what skills you know. The example I give when I'm training in the community, when I'm training in different cities is, you put me in front of a piano. I don't know how to play it. It's going to be bad. It's not going to work out well. Had no training in it, didn't take any lessons. So there's a big difference between that and cooking, which I've had many lessons in, and when I cook, it turns out well. So what's the difference between playing piano and cooking? It's got nothing to do with me as a person. It's got to do whether I had the skills and I learned them from someone or not. And so that's a really positive way of approaching our clients and their challenges, is saying, look, the reason you're stuck right here, or the reason you're having difficulties in this particular area, is you don't have the skills for that. So let's work that through. And as I mentioned in the last video, there are 4 modules in DBT that I think are really important. So one is distress tolerance. It's just learning how to deal with really intense emotion and put out those emotional fires yourself, not waiting for somebody else. Emotion regulation, learning how to self-regulate and knowing where that's coming from using things like emotion sheets. Mindfulness, research is really clear about mindfulness, that it can really help people with emotion regulation challenges. And then interpersonal effectiveness is your communication style, your communication skills with other people. Those are skills that can help you get where you want to go, get your needs met, even ask for things that you want. Very, very important skill to have. Now, another really essential part of DBT is they have something called treatment targets. And up until I had studied DBT, I didn't know what a treatment target was. So I'm going to explain this to you briefly. Essentially, when someone's coming to therapy or they're coming for help, even if they come to an emergency room and they're looking for help, it doesn't matter how brief or how long this interaction is. The fact is that every time you're working with a client in some way, you're looking at a target, a goal that they want to achieve. DBT has this interesting way of explaining treatment targets. So for people with borderline personality disorder, for example, the top priority with those 4 modules, why did I explain that to you? Because all those 4 modules are about increasing safety and stability. If you can teach clients those types of skills, they're going to feel more safe, more competent, and they're going to be more stable. Sometimes, actually many times, clients have to repeat groups over and over again, or they have to be exposed to the material over and over and again in individual therapy because they haven't learned the skills yet. It's the difference between knowing you shouldn't smoke and not smoking, right? You can have knowledge, I know, don't smoke, and then there's you're not smoking, you're actually doing the behavior. That's the difference between knowledge and wisdom. Knowledge is you know it, wisdom is you're doing it. Skills are really important because they teach you how to do it and do it consistently. The emphasis I'm trying to place in all these modules that I'm offering to clinicians and mental health professionals is what my assumption is look, I've got some experience in outpatient clinic care and I learned a certain set of skills, and maybe that can help you when you have clients with certain challenges or they don't have the skills and you're not sure what to do next or what you've been doing isn't working. So the same principle is, I think there's some skills that DBT has to offer that I'm showing you right now, and then that increases your skill set, and then you can go translate that into how you work with your clients. So for me, what therapy is about, or consulting or educating is about, is can we show skill sets? Can we improve someone's skills at something? And if we can, outcomes are going to get better. And if we can't, then the client's going to stay plateaued or stuck where they are. I like it because she's not saying that it's the person's fault. It's just you don't have the skills. This shift in emphasis is very empowering for clients. It's very encouraging. It keeps a good therapeutic alliance, and it allows you to challenge and support at the same time. Very effective. So with treatment targets from DBT, what they're saying is that because inside there's such chaos, because it's so unstable, stability and safety is key. And I would say when working with anyone, that is paramount for me, is I want to make sure those things are attended to first. Then in terms of treatment targets in DBT, they want to decrease post-traumatic stress-related problems. So that's like disturbed sleep. Almost every client I work with, whether they have a personality disorder or not, has disturbed sleep. They want to, there's going to be protocols around sleep hygiene, nightmare protocols, re-experiencing from post-traumatic stress disorder. Those are the types of things that, again, feel like they're out of the client's control. So we've got to help them get skills in order to work with that. Very important. And then the next treatment target after that are self-respect and individual goals. I actually have a module that I'll be going into later where we talk about how to create client-centered goals. But I just wanted to give you a taste, a flavor of what DBT has to offer in terms of what is a treatment target, how do we sequence those, and why are we doing that? I found this very useful when working with people with personality disorder and mood disorder. Now, dialectics. Dialectical behavioral therapy, obviously Marshall Linehan did not invent dialectics. That comes from a branch of philosophy. And in dialectics, what it's basically saying is that the universe there's duality in the universe. When there's light, there's dark, rich and poor, sick and healthy, hot and cold, left and right and wrong. Everything has two parts. And so in dialectical behavioral therapy, our clients have two parts. When a client's trying to do something, okay, they're trying to change. When they come to us, whether they're coming to a doctor or a dentist, or whenever they're engaging in any kind of service, they're trying to change something, right? That's why they come to us. That's why they want help. They can't do it by themselves. So they need to learn how to either receive that kind of care or learn the skills in order to implement that kind of care for themselves. So what is happening here is that inside of our client, there's a polarity. There's a positive part and a negative part, a light part and a shadow part. And I don't know for some clients which is light and which is shadow. For example, if a client has body dysmorphia or they have body image issues, is going to the gym and looking at the mirror and measuring their body fat, is that a healthy practice? Maybe not. Maybe they need to take a course on body image first before they go in there, about loving and accepting themselves rather than self-invalidating and going into the gym trying to make themselves look better so they feel better or feel like they can get the attention that they want. I'm not saying going to the gym is necessarily a healthy behavior. Similarly, I'm not going to say smoking is right or wrong. If you take away, and this is from Dr. John Briere, if you take away a client's crutch, whatever it is that they're using to titrate reality, okay, sometimes that can lead to something worse. So if you take away cigarettes, maybe that leads to drinking. You take away drinking, maybe that leads to fentanyl or opioids. We don't know what's down there. We don't know what they're coping with. We don't know what coping mechanisms they currently have in place, which may look maladaptive to us, but underneath, it's actually holding them together. All I'm saying is that when a client comes to us, they're working towards change. And I think it's our job to help facilitate that. So what I like about the dialectical approach is we're saying a part of them wants to change and a part of them doesn't. Okay, no problem. Here's where it gets tricky, is often they will say, what do you recommend? What do you suggest? What should I do? And it's very important not to take sides. Just let the client experience these dialectical or opposing forces inside of them and let them figure out how to synthesize that. So if we can have a part of them that wants to keep smoking because it's keeping them safe potentially, and a part that wants to stop, and we can work with how do they bring these two conflicting points inside of them together? How can you work with yourself together? Then they're going to make progress rather than starting and stopping. Oh, I quit for a while, but now I'm back. And oh, I tried the nicotine patch or nicotine gum, but now I'm back. And that's because they can't get that synthesis. I think that's very important in therapy, is to find a synthesis for those opposing points of view that they have inside themselves. So we're often working with, in DBT, which supports dialectics, we're working with contradictory or extreme positions. And how I do this when I'm explaining it to people in the community is it's like a figure eight. The client, let's say this is the part that wants to go to the gym and this is the part that doesn't. So, January 1st comes around, they want to go to the gym, but it's cold and it's snowy and the weather's bad. So, no, I don't really feel like going today, but I just saw how it is in the mirror for me. So, yeah, I really do want to go towards the gym and I want to start doing it. I'm taking it seriously. But it's there's a Super Bowl party coming up. There's going to be wings and beer, and I don't want to skip all that. So, no, I'm going to wait until March. And you know what I'm talking about, right? People have these inner conflicts all the time. In dialectics, you don't take sides. You just let the client work it through for themselves. As they go away from something and towards something, you stay with them in a non-judgmental, compassionate way. You're providing options, you're providing suggestions, and then they get to choose. They're self-empowered, they're not being invalidated, they're not told what's right or wrong, they get to figure it out. I really like that in terms of therapeutic stance. And again, therapeutic stance is what we say and how we say it. I think that's excellent in terms of building a good relationship, a good connection with our clients. We're also saying in dialectics, there's no one truth, there's a plurality of truth, right? So if a client's saying, well, I don't know about my gender, for example, like I'm gender fluid right now, I'm not binary, I'm not really male or female, no problem. I'm not going to be the person saying, no, this is right and that's wrong. Absolutely. Let them decide for themselves. That's what was missing a lot of times, is they didn't have empowerment. They didn't have choice back then. They may have been hurt or traumatized or invalidated. So we want to provide the opposite environment, which is where we're supporting and connecting and yet still moving towards the goal that they said that they want. And we want them to find a balance. So, for example, if you have a client who's saying, okay, I want to quit smoking, I want to completely stop, and right now they're at 2 packs a day, maybe a good balance for that client in the grand scheme of things is 10 cigarettes a day. Okay, it's not 2 packs, it's a harm reduction model, but maybe 10 cigarettes or 15 cigarettes is better than, I don't know how many are in a pack, 40 is 2 packs would be maybe 40 cigarettes. So you want to encourage the client, look, this is what you said you want to do. Here's some suggestions and techniques, and then helping them find a balance rather than taking sides. It's very, very common. It's extremely common that when you work with someone with a personality disorder, you will want one side to win. You'll take sides. Yeah, going to the gym is good. Smoking is bad. Oh yeah, you should work on your diet. And this is the stuff that we hear all the time in our society, right? I mean, we hear this, but in this case with dialectics, we let the client process it through rather than us dictating terms and telling them what to think or feel. That's already happened to them and it didn't work out so well. Okay, so our therapeutic attitude is we're going to be balancing change and accepting the client where they are. So if a client comes in, this is really important. A client comes in, let's say they're in my goals group or I'm working with them on a goal in individual session. So on the one hand, I'll say, oh, you said you wanted to go to the gym or do a workout at home, but I noticed that when you tell me about your week, you didn't do that at all. There's still an accountability, and yet there's still an acceptance, which is, I don't mind if you don't do your home workout. It's totally okay by me. It sounds like it upsets you, though. Do you want to talk about that? Or do you want to move on to something else? Maybe this isn't the right time. Maybe there's a lot of things going on in your life, and this isn't the right time to try to change that particular behavior. So it's this idea of accepting them and challenging, offering choice and change, reminding them of what they wanted, and yet not getting upset when they do it or they don't do it. So if they do whatever they said, they want to do a home workout and they're doing it 3 times a week, I'm not going to be over the moon about it. I'm just going to say, okay, that's good. That's really good. And I'm going to get into why I take a neutral and slightly positive therapeutic stance later in another module. But for now, I'll say that if we disapprove them, like, wow, that's bad, then it would imply that doing what we think is good is going to get our approval. Is this any different than than the parent taking the child into the ice cream store. If you're like this, we approve you, and if you're like that, we disapprove of you. So this is where DBT can be so useful when you've got people that are presenting with challenging behaviors or complex situations. Taking a step back, being non-judgmental, being mindful, tuning into your own emotions, and providing options can be very, very useful, so that we don't get embedded and entrenched or take a position when they're trying to say, I'm going to do this or I'm not going to do that. Of course, though, we're still attending to therapy interfering behaviors. If someone's coming in and let's say I've got a client and they no-show 3 times in a row, don't call, right? I have to attend to that, right? I can't just let them go indefinitely with no-show or showing up late or not doing homework, things like that. So there's got to be an accountability and a challenge, and we still have to support them and care for them and connect to them. And so one of the ways you can make peace with all this is to recognize that in dysfunction, there is a purpose. I was working with a client once who needed chaos around her. It was always something with her housing. It was always something with a partner, always something with a landlord or police. And what I learned over time from working with her was she needed a certain amount of chaos, because what she said to me was that when things are peaceful, when things are going her way, that's when she gets even more frightened. More frightened? But more frightened of what? She says, then I'm really going to lose something. So it's almost like clients can sometimes feel an impulse to do it to themselves before somebody else can do it. So there's function in that chaos, that her life was always in turmoil. It didn't give her the opportunity to really feel inside of her body, to really be in the present moment, because she had to deal with the next crisis. There's function in that. One time I was at a grand rounds with a psychiatric resident who was presenting, and he was talking about a client who came home to an apartment, and there was just this unbearable sadness and unbearable loneliness. And the audience was asking, like, what do you think the purpose of that is? And then a participant in the audience said, there's something underneath that's even worse. So for that gentleman who the psychiatric resident was working with, coming home to an empty apartment was more bearable than taking a risk of making new friends, finding someone new to be a partner with. And so there's function in that. You see, the client might have a heartfelt plea like, I cannot stand how lonely I feel. I cannot stand my social isolation. But there's function within the dysfunction. In that, the client is avoiding something worse. Let's use a case example to kind of contrast a little bit. We're just going to use something brief. So let's say a client says the following: I hate exploding when I'm angry, but I can't stop. Now, a typical response might be something like this. Yes, it causes serious problems for you. You've talked about the people you've hurt, the relationships you've lost, and the shame you feel after. I think you'll feel really good about yourself if you're able to change this. So let's talk about what will help you to stop. That seems completely reasonable. Now, let's look at this through a dialectical behavioral therapy lens, where we see those two opposing sides and we say, okay, wait, there's function within the dysfunction. So let's work this out a second. Client says, I hate exploding when I'm angry, but I can't stop. Here's the DBT response. Yes, it causes serious problems for you. On the other hand, it's effective. You like what it gives you. Let's talk about what you get from exploding, because you're not likely to stop until you find other ways to achieve the same thing. See? We recognize there's two parts. One part hates that they're exploding. The other part wants to keep doing it because it works. That's really important. I think you can hear the language, how it's warm and yet it's challenging. I think that's really, really important. When you have clients that get entrenched in positions, they're upset with you that you're not doing enough work, or they feel like you should be doing more, or why isn't this working? I've been coming to you for 6 weeks or 6 months or 6 years. Why isn't this working? Or why can't we get anywhere? Stepping back, not taking a position, letting them sort that out. It provides immense relief inside when you let them work with it rather than trying to fix, distance, control, the client and make something happen. If you feel inside like you got to make something happen, that's countertransference. That's your reaction to what the client's struggling with, and we can impose what we think is right on the client, and that generally doesn't work out very well. Now, dialectical behavioral therapy, we've talked about the D part in dialectics. Now we got to talk about the BT, the behavior therapy. Now, behavior therapy is about reinforcement, right? What are we reinforcing? If a client calls in crisis and you respond right away, every time, if they call early in the morning and you text them right back, or they call at 11 o'clock at night and you're right there, what are you doing? You're reinforcing them connecting with you when they're in crisis. And I've done many consultations where a clinician is saying, a worker is saying, I can't get them to stop emailing me, texting me, coming to the door, just as an example of some behaviors with the client that they don't know what to do. But I ask them, are you reinforcing this behavior? Are you encouraging them to contact you when it's a non-crisis situation? Because what we're reinforcing is very important, because if we say, even non-verbally, that's okay, then they're going to keep doing it. So we have to know how to set compassionate limits, and we also have to know how to support and help them move forward. So what we need to do is set clear guidelines about how to ask for help, when to ask for help. Here's an example. You've got a client coming to you, and their appointment is on Thursday at 2, and they call you on Monday at 1 o'clock. I'm in crisis. I need your help right now. Okay, you need to set a limit. Listen, here's what, you're not feeling safe right now. Please call this crisis line or go to the emergency department. Our appointment is for Thursday at 2. I want you to be able to look after yourself as best you can between now and then. Please help yourself get through this really urgent crisis. You may access, this service, this service, this service. I am looking forward to seeing you on Thursday at 2, setting healthy limits. If we don't learn how to do that, the next time they call on Monday at 1 and then we reply and we're on the phone with them for 45 minutes and trying to de-escalate them and talk them down, you can bet they're going to call on Tuesday, or they're going to call after on Friday because something's happened in their life. We have huge caseloads. We don't have the resources to help everyone like that. When you choose a therapeutic stance and when you're creating a therapeutic frame, you have to ask yourself, is this sustainable? Can I reply to every text? Can I reply to every email? Think about the message you're sending when you do or you don't. And think about how to have a conversation where you teach them, come on Thursday at 2 o'clock, like our appointment, for an hour, right? Teach them about being consistent. Teach them that you're trustworthy, you're going to be there, and help them learn skills to navigate the crisis before and not become completely dependent on you. This is just a small example of reinforcing certain behavior using dialectical behavioral therapy principles. And it's also important to explain the consequences calmly. Like when I was running groups and someone didn't show up 3 times in a row and didn't call, I would say on the very first session, total transparency. Oh, if you miss 3 sessions in a row and you don't call, we're going to assume you don't want therapy and we're going to discharge you. That way there's no surprises. It's not that they're not shocked later, like, why did you discharge me? I told you. But it's very important, if we want our clients to be emotionally regulated, that we're emotionally regulated. We are calm, we are relaxed, we are centered, we are focused, we're mindful. So part of the reinforcement that we're offering is how we talk to them, how we connect to them. We're modeling for them what we would like them to have if they want it. Everything's voluntary. They don't have to have it. We're not asking them to change, but if they're working with us, then some form of change is going to occur. Now, Freud has talked about this from the very first moment a client contacts you to the very last time they see you and say goodbye. There is resistance throughout. Kingston talks about this in 1967. Gabbard talks about this. Kernberg talks about this in transference-focused therapy. It's very important to recognize clients are going to resist change. Sometimes in DBT, what Linehan has is what she calls an irreverent or paradoxical stance. This looks similar. If you've had any training in motivational interviewing, MI, you'll see this is quite common. Client comes in and you say, oh, you missed our session last time. Oh yeah, I was really tired. I couldn't come in. So an irreverent stance or a paradoxical stance is, oh, of course you wouldn't come in when you're tired. Here's what we're going to do. We're only going to meet now when you're completely refreshed. If you've had any kind of trouble with your sleep at all, of course, there's no way you could possibly come in. Now, that's not mocking a client. That's agreeing with the client. They're saying, can't come in because I'm tired. All right, well then let's never book an appointment where that could be the case. I only want you to contact me when you're totally rested. And what that does is it helps them see, when you agree with them, it helps them see that actually there's some assumptions underneath there that need to be examined and talked about. So that's the point of the irreverent stance, is to highlight and showcase there's something inconsistent here where you're saying you want change, there's things you're going to want to do, but you're not able to make the appointment because you're tired. Another way of being in an irreverent stance is to take a confrontational tone. Remember, you've got a client, a part of them wants to do a home workout and a part of them doesn't. Client says, oh, I want to do a home workout. And you say, listen, the last 6 sessions, last 6 times you saw me, we've been talking about this home workout. And I think it's just crazy. What do you mean it's just crazy? Well, you're at home by yourself. You're not around anybody. You're putting yourself under real exertion. You're making a situation very challenging and difficult for yourself. You're causing your breathing to go very rapid. You're causing your muscles to ache or be sore the next day from the work that you've done. Like, don't you think that's just crazy? And what you're doing there is you're not taking sides. What often happens is the part of them that doesn't want to go, you're saying all the things that part is already saying. You already have all those objections. Similarly, if someone says, well, I don't want to go to the gym, you're like, oh, that's just crazy. What are you going to do? You're just going to sit on the couch all the time and eat ice cream and watch Netflix? Like, you're saying you're not going to move around at all? And the reason I only take that type of irreverent stance when this has been a prolonged chronic difficulty where a client's talking about a choice or a goal and they want to work towards it and nothing's happening. Sometimes just highlighting and underlining the thinking underneath that can create some movement into a different stage of change. So some clinicians that I talk to find that tool particularly helpful, because if a client keeps when I'm doing consultations, what people say is, look, this client said this over and over and over. They want to change this. They want to change their being in this toxic relationship. They want to change that they no longer want to live in an apartment where conditions are unsafe. What do I do? Well, sometimes you just have to agree with them and say, like, that kind of change isn't working, or that's just crazy, or you agree with them. When you do that, it helps them see what's going on underneath, the defense that's going on underneath. And then they can talk about them being upset that you're agreeing with them or challenging them. It's a soft way to highlight what is not working, especially if they keep saying they want to change it over and over. I can't tell you the number of consults I've done where someone's saying, I can't get this client to change. And I'm like, that's exactly it. You can't. You cannot. They have to want to do it. So one of the reasons I create this video is because clinicians often feel like they're not doing the work, or what have I got to do to make it work? In DBT, the answer is you don't. You provide a supportive, safe environment where they get to figure out what's working or not. Sometimes clients create goals and deep down they don't want to do it. And it's okay to give them permission not to do it. I'm giving you permission not to do it. If you've got a client who really doesn't want to change something, smoking, going to the gym. See, because what I think therapy boils down to 2 things. Either people learn to start stuff, such as I'm going to start going to the gym, I'm going to start meeting friends, I'm going to start going back to school, or our clients are learning to stop stuff. I'm going to stop smoking, I'm going to stop overeating, I'm going to stop gambling, I'm going to stop showing up for work late. Basically, that's it. And so they're struggling inside where a part of them wants to do it and a part of them doesn't. And DBT provides such a clear framework. I think this is so amazing because clients get stuck, they get entangled in different things. Remember when we talked about Timmy and Tommy with the ice cream, right? You might be thinking as you talk to a client, hey, what do you like to do when you go home? And they're like, well, by the time at the end of my day, I just want to sit down with some ice cream. Oh yeah? What flavor do you like? Well, I don't know. Sometimes I choose vanilla, but sometimes I don't really know what I want. But I just find it comforting for some reason, and I can't seem to stop. Part of me wants to because I'm seeing the weight gain, but a part of me doesn't. I don't know what's going on. Oh, all right. Well, let's work on that. And when you use this DBT stance, you can figure out the deeper dynamics of what's going on rather than what I call picking up the other end of the rope. When people have personality disorder or they're having complex challenges, I often feel like it's a tug of war in there, where those old games where people used to have rows and rows of people. They're all grabbing a heavy rope, and there's a kerchief in the middle, and one team is pulling it this way, and the other team's pulling it this way. And the tug of war is: do we win, or do you win? When clients are trying to change something and they don't know how to change it, oftentimes it feels like some kind of power struggle. Like, yes, I worked with you, so now I can stop my smoking, or, oh my God, you're the worst therapist ever. I have no idea why I'm here. Like, nothing you're doing is working, right? So it turns into feeling like I've got to be doing something more. Like, I get into wanting to pull them in a certain direction. I feel the urge to do it. In DBT, what I'm asking you to do is check that urge. Where'd that come from? What's going on? Why is that so important to you? And when I'm consulting with clinicians, they'll say, because it's important to the client. They're saying they want to change it. And I'll say, but do they? Are they? What's getting them stuck? So one of the things I invite people to do is don't pick up the rope. Don't pull on the other end saying doing this is good or doing that is bad. I'm emphasizing this a few times here for a reason. This runs deep. When we're mental health professionals, we think we've got answers. We've been trained to think we're the experts. Maybe we're master's prepared or we have a doctorate and we're thinking we'd better have some answers. But when someone presents in this way, I think it's really best that they find their own answers. And I like it that DBT has a way of handling when our clients are resisting and challenging the process, which is totally natural, totally fine. It doesn't matter what you're doing or what behavior you're talking about or what type of therapy you're doing. Clients are going to resist change. It's okay. It's fine. Now, there might be what we call client interfering behaviors such as absences, lateness. They might, if they've been diagnosed with borderline personality disorder, they might be hospitalized. They might threaten to sue. They might say they're going to report you to your superior. Or they might engage in lying. I don't know. I don't remember when you're asking them about something that you said in the last session. They can be non-compliant with homework or doing some kind of role play. There's lots of ways to resist. It's part and parcel of the work that we do. But what happens is when clients consistently or insistently have therapy interfering behaviors, it can cause clinician burnout. It can reduce our willingness to work with them. They can push our personal limits around when we take phone calls. They can get family members to put pressure on us or other community partners like, you better be doing this work. We're very concerned about this person. They can criticize you as in the work you're doing. They can criticize your organization or your workplace. They can use threats to try to get their way. These again are just methods of getting unmet needs met. And they can also push organizational limits. I'll give you an example. I was doing a consultation with an organization here in Kingston, and they were saying that one of their clients pulled out a knife and put it under a worker's throat, but no charges were laid. That same client also took a cinder block and threw it through one of the workers' windshields. No charges laid. Now, where you stand with all of that, that's up to you. What your policies are, what your organization is. What I'm saying here is that when a client interferes like that, it can frighten other people. It can make it so that it's a public safety issue where other people are concerned about accessing that particular organization and their services. So when we're, obviously that's an extreme case, but I have consultations like this all the time where people are having extreme behavior and they don't know what to do. Organizations don't know what to do. So pushing organizational limits like that can make it really challenging, not just for that client, but for other people. And one of the things I think about is the impact on everyone, not just on that client. But that is a form of client interfering behavior for sure. Now, therapists also can interfere with behavior. There's a amazing book called The Bipersonal Field, written in 1976 by Dr. Robert Langs, and it's incredible. I'm going to definitely talk about this in other videos around what he calls the misalliance cure, where what we think is working isn't actually working. We're just doing it because it makes us feel better. So now we've been talking about continuums and things being on a spectrum. So, or a part of us wants to do it and a part of us doesn't. Some therapists get focused more on acceptance, and then sometimes we get focused on how do we change ourselves to make this work. So we either got to accept the client as they are, or we've got to create some kind of change. These are on a continuum. Another dialectic that you'll encounter when you're doing work with clients is you're being too flexible or you're being too rigid. These can be challenging. You're creating problems and challenges in the situation from what you're doing, what you're thinking. And another challenge and another spectrum of dialectics that you can have is where we're being too nurturing, too supportive, or we're being too demanding, too insistent of change. Any one of those in DBT is considered a therapist interfering behavior, which I think is a really interesting conversation, because I don't think therapists realize how much we can get in the way. Some concrete examples of this is we're having a lack of respect for the client. For example, we might be late for appointments, forget about appointments, we cancel appointments, we allow interruptions, like while we're working with someone, we allow someone to come in, or we're taking a phone call. We can watch the clock while the client is talking or treat them as inferior. These are all considered therapist or worker interfering behaviors. So before I studied DBT, I had no idea. I didn't even think about those types of things. And Robert Langs goes in depth in that book, The Bipersonal Field. So all that being said, we're getting to the end here, and I'm making 3 suggestions. Please don't, right? Please don't make your client's problem your problem. Don't pick up that rope. Don't make it that here's the thing. If they're doing well, if they're getting better under your care, you start feeling good about your work. And if they're not doing better, if they're getting worse, you start feeling worse about your work. Your work has nothing to do with them, whether they respond or not. Don't make their problems or their success your problems or your success. Next, don't get into power struggles, as I talked about, and don't provide a solution until you have a good sense of the problem. Really listen. Take time to listen. Hear what's going on for them, and then make an informed decision as to what, in your mind, as to what you're going to suggest. I think a lot of times when I'm working with people, there's this temptation to just problem solve and get through the next thing. Rather, take in the information and let them find solutions. And if after that they need some help, then you can make some suggestions. Now, 3 things about please do. Please do, when you're working with clients with complex needs and very challenging behaviors, please breathe in and be empathic and listen to your own feelings. Pay attention to them. Pay attention to those 6 elevators inside of you. What's going on as they're talking? What things are getting you upset? What things are making you feel afraid? What things make you feel angry or frustrated? Be really clear about your bottom lines. So, as I said in the last video, Introduction to Personality Disorder, where is your line in the sand? Are you okay with workplace violence? Are you okay with verbal abuse? Are you okay? Like, I know that sounds like I'm being facetious. I'm not. Some places honestly don't have policies in place about that, or they think they're doing something wrong. In this current environment, I'm finding in Canada is that particularly in Ontario, we're in a very, if it's like a pendulum, we're in a very supportive phase right now. We're just about supporting and recovery. There's a lot of language about that, but there's not much on the other side around challenging. So thinking about things, taking a step back, talking to peers, talking to your team, talking to leadership about like, where are we on this? Like if a client acts in this way, like what is our policy on that? Or what is my policy of that? What's my college's policy on that? We want to think about these things and be really clear about what our bottom lines are. I think that helps a lot for stability, and also in terms of confidence and just knowing that you're doing good work. And then lastly, be calm, be creative, and sometimes it works to be disinterested. In other words, don't be attached to the outcome. If the client does better, okay, great, that's their choice, that's their success. If the client doesn't do better, okay, maybe right now isn't a good time. Intermittent therapy, there's some research showing that if a client's in a series of crises right now, this may not be the best time to try to create change. So why not they come down 2, 3, 5, 6 months from now, reapproach, try again, take groups again, repeat things again, learn skills. So it's not being tied up in their success or failure, their outcomes or their happiness or their contentment or not. What DBT invites us to do is to just do what we do the good work that we're doing, and then just let the outcomes, let the chips fall where they may. I think that's very important, that we don't get wrapped up in whether the client's doing better or not. We gotta offer what we know from the research and evidence-based practice, and what we think is ethically right, and then we gotta just see where that goes. All right, so if you found this video useful, please hit the like button or write some comments down below. Let me know what's going on for you as you watch this, as you go through this. If you want to reach me, my email is michaelbruinix@gmail.com. That's michaelbruinix@gmail.com. And if you're new here, consider subscribing and select the bell right beside it to allow you to get notifications when new videos come up. And I sure do appreciate your time. Thanks so much for watching, and I look forward to seeing you on the next one. Bye for now.